We are grateful. As we start this day, we dedicate it in your hands. We pray that you'll be able to guide us. We pray for knowledge, wisdom, understanding. We pray for unity. We pray that we shall be able to have final decisions and takeaways from this meeting that will be implemented. We pray for those that have not yet come to come peacefully. In the name of Jesus Christ our Lord, we prayed. Amen. Amen. Good morning once again, ladies and gentlemen. My name is Robert Mugera, and I'm delighted to be this morning part of the team that is supporting to ensure that you get the best service. So in our midst, we want first and foremost to thank all those that have supported this meeting, including Makerere University. I think at this point we are going to appreciate those that have supported us. Makerere University. Please clap for Makerere University. Thank you so much. Would we please appreciate IDI? IDI has done a good job. Can you clap for IDI? Thank you. You know, when you appreciate others, they will also appreciate you. Japaigo, thank you so much. CFID, we are grateful. Please clap for CFID. Choir AI, thank you. Thank you for the support. UNICEF, our friends from UNICEF, thank you for the support. Tasso Uganda. I hope we don't have Tasso Kenya. Tasso Uganda. Clap for Tasso once again. MRC, thank you so much. We highly appreciate. Gavi has supported us. Path Uganda. We have Chai. We have AHF, Uganda Cares. Thank you so much. IDRC, we are grateful. Malaria Consortium, thank you, Malaria Consortium. Now, among those that have supported this conference is an organization called Maisha Maids. Maisha Maids is an organization that works and supports the private sector channel of delivery of services, and they provide subsidized services through the private outlets. And at this particular time, we want to welcome Maisha Maids. Maisha Maids, represented by Narumu Bridget. Please, as we welcome her, let's clap for her so that she's more energized as she comes. Thank you so much for the support. We are grateful, and we are very sure next year by this time, we shall once again be able to have this conference. Please. Welcome.
Good morning, everyone. Good morning. Am I audible? Good morning again. My name is Bridget Barbara Nalumo, recently Mrs. Makuta. I'm very happy to be here, very happy to be encountering you all. Like I have been introduced by Mr. Mugera, our organization is called Maisha Meds. Maisha is Swahili for those who would understand the meaning, and meds, just a shortcut from medicine. So I'm going to present to you this morning just a bit of the amazing work we've been able to do in Uganda, but of course in other parts in Africa as well. We are in Tanzania, Nigeria, and the rest as we are going to see. So we are at the Uganda National Communicable and Non-Communicable Diseases Conference, and we are very happy to have supported. And what Maisha Meds does is that we design software to advance high quality, affordable, and integrated healthcare in Africa's private sector. And I know integrated is our key word this morning, so I hope that you'll be able to see integration all through my presentation and our systems at Maisha Meds. So we design software, like I said, for pharmacies, for clinics, for drug shops in the private sector. And we've been able to create the largest network of pharmacies and public health or private health facilities in Africa. So we work with over 5,000 sites in Tanzania, in Kenya, in Uganda, in Nigeria. And we're able to see that most of them are peri-urban and in the rural areas. So we are in the last mile. We show you the journey of the commodity, of the health product to the last mile. And so we do this through our mobile business software. We have a technology that we're able to give to a pharmacy, we're able to train a drug shop to use, and they're able to use it to replace pen and paper while they're taking care of their patients. And of course, we also have patient support programs. These we are in areas like malaria, we're in HIV, women's health, vision, and many more that we're working in. We're in TB in different countries across Africa. So we're also able to use this health and market data to help make decisions. So we are helping governments make policies that are based off of evidence that they're able to see and integrate with the evidence that they're getting from the public facilities with the ones that we're able to give them in the private sector. And our impact really has been massive over the years. We started in Uganda in 2021, and right now we are seeing multiple patients being able to access care, quality care, because the processes that we use in our system, we are able to standardize them by the WHO standards, by the ministries of health, and so we know that these people are receiving very quality and affordable care. So when we power our integrated service deliveries across these private facilities, it's in different disease areas, like I said. And so that is a picture of what our software looks like when there are different care pathways. There's a very high level of integration that a facility is able to implement these different programs, different care pathways in the same area, in the same platform. So we have malaria, you see HIV, PrEP, and PEP, and there's a women's healthcare program that we had where we designed a card where they could be able to save for healthcare and access it affordably, but also easily without having to spend out of pocket. So we have one digital platform, multiple programs. We're able to see integration in that way. We are enabling TB screening with referrals at public facilities. We are seeing a very efficient coexisting ecosystem. So we are driving efficiency as well and real-time responsiveness. We're able to see this data in real time. We're able to have visualization to share this information as fast as possible. And we're also leveraging real-world evidence to power this integration. The evidence that we are able to collect, we are learning from our facilities. We are able to see that if this is implemented this way, this is the effect. And so we're able to iterate as fast as possible. And of course, I want to share with us some real life examples of the programs that we have been able to implement and that have shown us very amazing results. Okay. Okay, I went slightly ahead, but no problem. The final point that I wanted to make on us powering integrated service delivery is the clinical decision support for integrated high quality care. So we're able to see, for example, a pathway like for HIV PrEP, a client is able to be screened by the standards of WHO, of Ministry of Health. They get their HIV test result. We're able to take them through risk assessment. There's counseling, very standardized, there's clinical check, and then they're able to be initiated on PrEP or referred to a public facility. So one of the examples that we can give right now is the Uganda project that we are beginning, catalyzing integration in the private sector. We've named our project the AMDIS program, and that is alternative mechanisms for delivery of integrated services. And so this is integrating malaria testing and treating with HIV prevention. And we're housing both of these pathways in our system across very many facilities right now in Uganda. HIV, we are also piloting this month in Mukono, and we're also going to be in Wakiso. So of course, any more questions that you might have, because I have very little time, we can be able to discuss at our desk outside. It's just on this other side of the room. So this is one real life example. We are supporting clinical decision making at our point of care. We have set up the systems very standardized, and clients are very happy to be receiving these services. Another example that we have is our program in Nigeria, where we are expanding HIV treatment and TB screening in the private sector. This has also been very impactful because the program is aiming to expand access to ARTs and TB screening. I know this is one of the main areas that we are grappling with at this conference, but in different sectors as well. So, but we're doing this through the private facilities, but this data is able to be communicated to the public sector, and they're able to make very informed decisions where policies are effective, policies are based off of evidence. Of course, this is also generating real-world evidence to inform scale-up. And so when this project is able to be scaled up across the whole country, across the whole of Africa, effectiveness is assured. So I want to just briefly talk about our data as a window into the private sector. Of course, all through this conference, we've been talking about private sector. It seems to be quite blind. Every private facility is doing as they see fit. But with MyShames, we've been able to bring them together, to be able to coordinate together, to be able to also work with the public facilities in their regions to see to it that the communities are receiving the best of care at the most affordable price and in the most efficient way. So our data is able to support this visibility into the private sector. We generate real world insights that inform policy and are guiding integrated health planning. As we think about integration, it's very hard to have information on one area and lack information on the other. The policies that will be set and the plans that will be set might still not be as effective for the one area that doesn't have information. So we have information, and these are just some of the graphs that we had on non-communicable diseases. And we're able to see that private facilities are actually selling NCD meds. They are selling them when a client comes, they just, they are able to just dispense them, they're dispensing them, but we don't know at the rate. So we were able to see that they are actually supporting these patients with NCDs in a bigger way than even data had been able to show before. So this window into the private sector is that our digitalized tools will provide this real-time data from pharmacies, creating that visibility that provides now better community health delivery. The insights inform health policy. We are working with Ministry of Health. We are working on integrating with DHIS, and all of this we know is going to be very impactful. And of course, we are powering and we are strengthening the public-private collaboration, and these insights are enabling and empowering governments. They're able to bridge the relationship between the public and the private and be able to provide healthcare systems that are efficient. Thank you very much. Any questions and comments? I believe we are going to wait for you at the desk because I believe I've run out of my time, but thank you very much. I will be waiting for any comments.
Colleagues, you can appreciate MyShames again. Thank you. The comments, I can see the questions already coming from the commissioner. They have a desk outside, so during our time for the poster viewing and discussion, please reach out to find out on what more work they are doing. So we are quickly going to have a 5 minutes recap of the key issues. And Semei, I request that you focus on the key issues that came out of yesterday's session, and also touch on what was in the breakout rooms so that we are able to keep following. And as the rapporteurs do this, I remind you again, please keep giving in more information in case they have finished the update, because today they have to prepare a conference paper on the key actions and recommendations that we are going to move on in the next way forward. So Semei, welcome. Take us through the recap.
Thank you so much, Michael. Good morning, ladies and gentlemen. We're here to go through some of the key areas and the highlights of the conference for the previous days, and specifically I'll focus on what transpired yesterday at the plenary and in the respective breakaway rooms. As I wait for I would like to extend appreciation to the rapporteur team. Thank you very much for the work that you're doing. I would like to inform you that we shall have action points picked and documented very well. But for following up, we have research forums at the ministry. Kindly endeavor to be joining them every first Friday of the month, so that we're able to grow whatever we're discussing here into a better action points. So whatever is here, we shall grow it in those research forums going forward. But also reach out to a number of you people that have presented here to have whatever you've shared discussed further at that, and the research forums will have adequate time to discuss all the sciences that you've shared in here. In a nutshell, we again looked at day 3, and what came out much to define our day 3 was innovation, integration, and transition. The objectives, the presentation outline is that the objectives, key themes that were covered, presentation highlights, policy, our practice, recommendations, and then notable quotes. The objectives will strengthening health system resilience amidst declining donor funding, but also advancing integration, domestic financing, and community-driven approaches in communicable and non-communicable diseases care, sharing innovations and lessons from research, policy, and practices across Uganda. The key themes that were covered yesterday included domestic health financing and accountability, climate change and health system preparedness, integration of HIV, non-communicable diseases and TB care, antimicrobial resistance, and One Health approaches. Some of the highlights were from Dr. Emmanuel Batiwe, the regional the Director Regional Referral Hospital Mubende, who showcased regional innovations in resource optimization and staff motivation. Professor David, who argued for strong governance, data-driven accountability, and local financing, proposing at least a 50% domestic financing by 2030. And climate change, they had a climate change team that really advocated for and they argued investment in climate resilience, health infrastructure, indigenous knowledge, and early warning systems within, as we're looking at multisectoral and then integrating everything. So climate change came in. Dr. Christine emphasized Africa's shared learning and inter-country cooperation for sustainability. Those were the highlights for yesterday's conference. Then what are the cross-cutting issues that were picked out? Gender and equity gaps in sexual and reproductive health service delivery, limited preparedness for climate and environmental shocks, heavy reliance on donor funding and fragmented financing mechanisms, and also the weak integration between communicable and uncommunicable and mental health programs. We anticipate that after this conference, that cross-cutting issue number 3 will be will not be discussed anymore, because we're looking at a cohesion and enhancing the integration. Some of the practices and recommendations that were pointed out yesterday include the expanding climate change adaptation training for health workers, but also strengthening community-level surveillance and EMR stewardship, promoting innovation funding and public-private partnerships, and then scaling up domestic resource mobilization and enforce financial accountability. These are some of the recommendations that came from some of the highlights that were in the previous slides. What are the innovations? AI-based CVD prediction models for people living with HIV. Some participants are looking forward to having that scaled, but also digital TB trackers and GIS-based screening tools as one innovation that's going to solve the problem. ABRA self-care model for mental health wellness, and then so climate adaptation. So if we're looking at the integration, then we need to have some of these models coming to support the integration, where we have mental health, TB, non-communicable diseases, and then communicable diseases, but also focusing on climate adaptation models using indigenous knowledge. Many times they indicated here that we're relying on information that's not based here. So if we have information that's our indigenous knowledge, perhaps this will be a bit better than the current practice. Some of the quotes we picked were: health system resilience begins with self-discipline and accountability. Mental health is not a luxury, but a necessity. Indigenous knowledge is key for climate resilience. And then integration works. Integration works when all sectors move together. And lastly, some of the takeaways. One is domestic financing and integration are key to resilient health systems. Community engagement and innovation drive progress in malaria, sexual and reproductive health, and TB programs. And lastly, mental health, climate change, and One Health approaches must be prioritized for sustainability. Again, thank you very much. May God bless you and have a great day.
Thank you, Seme and team, for taking those notes. Indeed, it's not easy, but with your support, our dear delegates, we hope that you'll continue to help us and the team so that whatever is captured continues to reflect the key issues that we have been able to discuss here. So as we set the stage for our session for today, we must be reminded, or I'd like to remind you, that today is a special day. Not only that we are coming to the climax of our conference, but we are also having a memory of one of the great service providers in the country, whereby we shall be having the Dr. Matthew Rukuya Memorial Lecture that will be taking place in this very place where we are now at around 2 p.m. And this one has been organized by the Uganda National Association of Community and Occupational Health, the UNOC, to make sure that we keep remembering, but we don't only remember, but we also, what lessons do we learn from such great actors? I see our session chair has taken her seat, and as we also get to make sure that the panelists and the presenters get ready, I would like to borrow only 5 minutes of your time for us to set the stage by having a look and listen at a small documentary that will set our day as we remember the works and refocus as we try to address the issues of communicable and non-communicable diseases as we move forward. So the IT team, please play that short documentary, and then after that, we should be able to start our first session.
Today, we remember Dr. Matthew Rukuya, a physician, a leader, and a hero. In late 2000, when Ebola struck Gulu, Uganda, Dr. Rukuya, already pursuing his further studies in Kampala, rushed to Lachoro Hospital to confront the deadly outbreak. He quickly recognized the danger, organized isolation wards, trained staff, and led community awareness efforts. Amidst fear and uncertainty, he stood at front lines, putting the lives of patients and his staff above his own. Dr. Rukuya's courage and humility defined his life. Despite opportunities to serve elsewhere, he chose to remain in his community, devoted to saving lives where the need was greatest. He cared deeply, not for recognition, but for the people. When he fell ill, his last words captured his heart and mission. I'm going to die now. I pray no one would ever have to die of this disease again. On 5th of December 2000, he passed away, becoming the ultimate casualty in the fight against Ebola. But his spirit endured. With robust rapid response coordination, surveillance and contact tracing, and continuous preparedness, supported by communities and international development partners, his sacrifice laid the foundation for these life-saving systems. 7 years after Matthew Rukia, another hero fell. Dr. Jonah Kure Ubunduwijo gave his life to care for his people during the deadly 2007 Ebola outbreak. He turned down very interesting jobs, lucrative jobs in Kampala, to return home, serving in a district where a few dared to go. When the mysterious disease struck, he treated patients tirelessly, fully aware of the danger. Yet when he fell ill, isolation and fear kept even fellow medical staff from helping him. On 4th of December 2007, Dr. Kule breathed his last, leaving behind a grieving wife, 5 daughters, and a son born 3 months later. His courage, selflessness, and devotion to his community are a haunting reminder of the cost of a true heroism in healthcare. This short documentary is a dedication from the organizing committee of the National Annual Communicable and Non-Communicable Diseases and the 19th Joint Annual Scientific Health JASH Conference of 2025. In honor of Dr. Matthew Rukia, his family, the nation, and all healthcare professionals who continue to serve with courage and devotion.
Thank you, colleagues. The hand clap to the organizing committee for that. And maybe I would like us, if we can stand for 1 minute, a moment of silence in memory of all those health workers, in addition to Dr. Matthew Rukia, who have lost the battle in line of duty. May their souls rest in peace. Okay, we are going to go into our first session, but before that, I would like to recognize a special group that has been with us, Commissioner, for the 5 days. We have had district leaders attending consecutively and contributing to this discussion. So our district leaders, the chairpersons in the room, and the chief administrative officers from the technical arm, we are glad to have you in this room. Thank you for being part of this. And we request that as you get this message, we find a way of supporting you to simplify it so that it can reach the communities. The rest of us, the health workers and others in the professional healthcare institutes, we are being recognized in due course. So at this note, colleagues, I hope whoever is in the room has fully registered. Whoever is in the room, ensure as you registered, they issued you your lunch coupon. because we shall be going for breakout sessions after, and they may not come there to give you another coupon. So ensure you have it, ensure you have registered. Also, keep an eye on your variables and know the person next to you. I would like to welcome Dr. Susan Chiwanuka, Associate Professor, Mackay University School of Public Health, who is going to take us through the first session for today that will be looking at advancing multisectoral action for the prevention and control of communicable and uncommunicable diseases in Uganda. Join me to welcome Dr. Susan on stage to take us through.
Thank you very much. Good morning, everyone. A warm good morning to everyone. Yes, I am honored to stand before you to chair this session of this year's jointly delivered JASH between Makerere University College of Health Sciences and the Ministry of Health. My name is Susan Chiwanuka, and I will be chairing a panel. So we have decided to go ahead with the panel first before we get the keynote speech, because the keynote address has not yet arrived. So I will invite my available key panelists to join me on the platform. I am informed that Dr. Isaac Sinnabulya of Uganda Heart Institute is around. Dr. Sinnabulya, kindly join me on the platform. And I don't know whether my sight serves me well. I think I can see Dr. Grace Sally Chiwanuka. Please join me on the platform, and thank you for coming in the nick of time. I will also invite Ms. Shali Kansabe to join us. Shali Kansabe represents academia. Dr. Grace Sally represents the private sector. So today you're honored to have two Chiwanukas before you. Grace, please come over. And as soon as Mr. Baguma Bezo arrives, please let me know if he's already here. Please join us as well. So earlier this week I had the privilege of representing the Dean School of Public Health at the convening of the validation of Uganda's compact towards universal health coverage. And in that compact, they had 6 pillars with which they intend to achieve universal health coverage. Those 6 pillars included community health, service capacity, the workforce, financing, multi-sectoral collaboration, and governance. So today I am very pleased that we get to speak to this issue of multi-sectoral collaboration. It is a very interesting issue, but it's also very complex. So the questions we ask and discuss here today will hopefully get us in a better position to understand what it is, how we can deliver on it, and how to measure whether we have delivered. I think we have the right people in front of you. So I'll get started. I think I want to sit down. So I'll send my first questions to Ms. Grace Sally Chiwanuka from the private sector. And I will ask, before you speak, you'll just briefly introduce yourself, and then you will answer the question. So the private sector is huge. We usually think the private sector is these drug stores we see and the health providers, but we have a huge private sector, and it's viewed as a funder or a service provider. How can businesses actively contribute to disease prevention and health promotion in Uganda? Ms. Grace Sally.
Thank you, Dr. Chionuka. Good morning, everyone. My name is Grace Chionuka. I'm the Executive Director of Uganda Healthcare Federation. We're the umbrella body for the private health sector in Uganda. We've been in existence for about 15 years, and what we do is we bring together different components of the private sector, from service delivery in health facilities to health professional associations, to manufacturers and diagnosis companies, logistics companies, anything and everything that is outside of government that deals with health. We have associations in the country that join the federation as members. So that's really the brief background of what we do. We are part of the Health Policy Advisory Committee. We work closely with the Ministry of Health, and we co-chair the Public-Private Partnerships Technical Working Group under the Ministry of Health. So it's actually a very interesting conversation when we talk about multisectoral collaboration when it comes to health, because health is increasingly becoming dependent on other sectors, and other sectors indirectly are dependent on health, not only for the human resources they use to produce the goods, but also their consumers, and also to look at employment and different dynamics around health. And historically, when we look at issues that arise in health, everybody believes that they're health sector issues. When we developed the Universal Health Coverage Roadmap 7 years ago, we came up with an interministerial committee under the Ministry of Health that was appointed by Dr. Twine, the permanent secretary. And what we found when we had the inaugural meeting, we had people from agriculture, from ICT, from education, all the different sectors that we have in this country. But the majority of the participants in that meeting kept asking, but what does this have to do with my sector? So we had to explain to the people in education their role in sharing information and making sure people can actually even understand and read their prescriptions. So education had a key role. When we looked at roads and transport, of course, that one we all know when it comes to road traffic accidents. When it came to ICT, we talked about data and the importance of having accurate data when UBOS does a census, when it comes to analyzing that data and modeling when we're planning for the country. So it's also important for us to recognize the basic principle that most people outside of the health sector don't understand their role in health and how they contribute to the success of the initiatives and policies of the health sector. The other thing I wanted to touch on when we've talked about some of the things that the moderator has mentioned is we've had the private sector outside of health participate a lot in health. It's obvious what the health private sector is doing. We have facilities, we have diagnostics. And when it comes to NCDs, we invested heavily in bringing in camps, bringing in specialists from other countries, bringing in diagnostic systems, making sure that we bring in simpler and easier to use diagnostic mechanisms and equipment that would allow people at lower level facilities to also be able to do some screening. Because as we all know, when it comes to NCDs, early detection is key. So we've tried to make sure that we invest heavily in that space, but increasingly it's obvious that that is not enough. So we need to do more. And to do more, we've seen the non-health private sector come in. We've seen the one that most of us know is Rotary or the Lions, who do a lot of sponsorship, they do a lot of crowdfunding, and they do a lot of events where they're trying to bring in money into the health system. But it tends to be siloed and specific. So you'll see a run for maternal-child health, or you'll see a run to see how we can help support family planning better. But you won't see a lot that is health system driven, where it is synergized with other areas of government that the health sector is focusing on. You won't see much on NCDs, because NCDs don't tend to be a very attractive area for people to put money, because it's something that comes gradually over time. People don't see the impact directly and immediately. So with that, it's not something that people want to put money into because they won't see the direct impact. They won't see the direct result. You don't hear, oh, we did a campaign, we've screened 10,000 people for hypertension or diabetes, because it is not an area that has historically been attractive for impact and numbers that are meaningful to the everyday person. In this room, there are probably a number of people struggling with conditions and symptoms that they don't know are probably related to a non-communicable disease. So that level of awareness is something that the private sector needs to come in to do, but we have a number of missed opportunities. When we had COVID, for example, the private sector came in to support with donations, with contributions, not only financially, but also in kind. But we didn't use that opportunity to build on that. We didn't say, right, so we've seen who can do what. Let's have a discussion. Let's have a committee. Let's see how we can meet after COVID to keep having those conversations and those channels of communication open. So that opportunity was missed, because now when we need people to come in for Ebola or Mpox or even NCDs as we're discussing them today, there's that disconnect because we've left such a big gap in communication to make sure that the right people are in the room. And one of the things we tend to do as Uganda is we tend to be in emergency response mode, where when the big problem comes, okay, let's run and get private sector to see if they can contribute. But the private sector tends to have donation fatigue, financial contribution fatigue. They're not seeing the value proposition, and even the money that they're putting in has to show a return on investment to shareholders, to management, to the board of directors, the board of trustees. So as Uganda, we really need to think a little more strategically when we're engaging private sector for multisectoral engagement. We need to be consistent, we need to be clear, and we need to be coherent. Because like I said, we tend to work in emergency response mode and tend to just plug in what we can, where we can, how we can, rather than saying, what do we need to do for health system strengthening to prepare this country for the upcoming challenges that we're going to have with NCDs as one of the fastest growing conditions in the health system. Thank you.
Thank you very much, Grace. Actually, you've opened up a very exciting thing. I look forward to discussing this with you on this stage. Dr. Sinabulia, if you could redesign Uganda's approach to disease prevention, what would a truly multisectoral model look like, and what would be needed to make it work in practice? Thank you.
Thank you so much, and good morning, everyone.
Yes, please introduce yourself a bit more. Thank you.
Yes, my name is Isaac Sinabulia. I work with the Uganda Heart Institute. I'm a consultant cardiologist there, and I also head the outpatient department. I'm also a teacher. I volunteer with Makere, a researcher. I lead a research initiative called Uganda Initiative for Integrated Management of NCDs, which is an interesting body that brings academia, policy, and MOH on the same table. And this has helped us translate many things in real time because of that single table, all players in the same room. I'm also a patient advocate. I lead the rheumatic heart disease patient support group as a patron. So thank you for this opportunity to be here to discuss cross-cutting issues, multisectoral approach to prevent, because we know when you talk about NCDs, if we don't prevent them, we're going to spend so much. So conversations around being intentional to prevent them are really, really valid, lest we run into trouble. And the opportunity also to discuss that it does not only affect one sector, like how Mrs. Chiwanuka was highlighting. It affects every sector, because those lost hours at work because you've escorted somebody to the whole health center, or you are admitted, if somebody gets an accident, all those things kind of feed into each other. So to respond directly to the question, if I was to redesign the approach for disease prevention, what would a truly multisectoral model look like? The good news is it has been actually designed, and it looks at all the components. Who are the players? What can they do? Roles have been defined, intentionality around that. But I think the bigger question is, how do we actualize that good plan that has been put on paper? We need to be intentional. Some years back, we did a commission around NCDIs, and we found that 60% of these diseases or conditions are in the community. So in our implementation, we need to actually pay particular interest in the communities, because that's where the bulk of the work is, in the communities where we come from. the schools, the markets, the faith-based places, name it, because the bulk of the problem is there. So we need to have mechanisms where we all come in, the various players. For example, the OPM, I'm glad the person from there is here. They have a lot of programs there, but we need to work together to design packages and solutions that can actually help us tackle. How do we equip and fight the illiteracy rate? How do we make our people to get to know that non-communicable diseases are a challenge and a problem, such that we can actually work together and empower them to prevent? Because when you look at health, many times they look at Dr. Senaulia is going to do big things, but we forget that the patient has a pivotal role. And how can we use all these sectors to empower that individual? Because in chronic care management, we talk about self-care. How do we empower that person to self-care for themselves? Not only because they have a disease, but also to think on how can I prevent it? That when you, there's a program we want to do in the markets, because just imagine somebody sells fresh fruits, but their lunch is junk food. I mean, that's a lie, because you're selling things that are healthy, but you're not consuming them. So how do we package education models and let them know that you can actually still eat healthy in a busy schedule? So there's so much that can work around there. And also data solutions, because we know, and ICT has revolutionized, and in this conference, they've been talking about some of the models. How do we tap into the ICT sector to be able to make data collection easier so that we can use it to plan and troubleshoot? Because some of these problems are glaring and they're obvious, but we've not documented them. But how can we collectively be able to map them out? Talk about education. Our children, sometimes I'm on a parents group and the discussions are a bit interesting, but I won't go there so much. But can we influence even the curriculum? That from primary, we educating children on healthy living, on being intentional to be screened early, on how to be active. I mean, you find an entrepreneur who has 100 by 100 feet and is putting a school. Where are the kids going to play from? What are they eating? When you look at their canteen, the things that are there are things that are detestable. But because we are busy, we don't even care to know what's happening in there. So the opportunity, I'm emphasizing community because it's broader, and that's where the bulk of the work has to be put. So even when you look at the levels, secondary education, tertiary education, medical school, legal, whichever education there is, can we have modules that help us to think about health sector and what can we do? That lawyer, as you're arguing a case, can you push in a few things that can actually help to educate and inform the people, the audience that you have? Sometime back, I lost one of my patients, and the family requested me to give a talk concerning prevention. Initially, I was actually a bit scared and skeptical, but the daughter told me, Isaac, this is to be done in honor of my father. That can you talk to the masses? Because many people attended. And I realized what an opportunity to speak about prevention to the masses, because there were diverse people that had come. And then we realized that we can actually use churches, mosques, markets to be platform to encourage prevention. So that when people go, but also because their literacy levels have been improved, they would know what those numbers mean, what risk means to them, and how can they plan better to avert some of those risks. Talk about, the levels of healthcare in this country. We have the community, which has the bulk, but Health Center 3, Health Center 4, Health Center, District Hospital, Regional Referral, we need to work in unison such that we actually can plan better to be intentional. Also remembering that curative is part of prevention, because you're preventing complications and you're preventing expenditures that can be associated. The role of academia, I can't really overemphasize that, but I realize that all the sectors, we need to be speaking the same language to speak in unison, and with that we'll be able to actually tackle most of these problems because they are glaring. But the information has to be sent out there that we empower that individual, that homestead, to be able to take charge and be able to advocate because they are professionals. Like you look in my family, we have lawyers, we have engineers. If we sit on the table, when we discuss health, what are they taking into their sector that they can innovate? That these roads, I'm so happy that there's a lot of construction actually, and the walkways are being emphasized. To me, that's a great step in the right direction. As we construct these roads, are we thinking about the pedestrians? I do most walking when I'm abroad because the walking ways are safer. And I'm happy that we are making them safer also here, that our transport, our councils are being intentional. Green spaces, because instead of erecting that mall, can we preserve these green spaces to be intentional? When you're giving a permit to a school, can we say, if you don't have where children will be able to run, don't, and we don't certify or give them accreditation? Because if we do it that way, we're going to be model a healthy population that is so intentional. Thank you.
Thank you very much again, Dr. Sinavulia. I'm glad that you have delved into the need to start from way before the facility if we are to address the challenge of non-communicable and even communicable diseases. Not just creating awareness, but providing supportive environments for that. I'll first go to my next panelist, Mr. Baguma Bezo. I hope I've pronounced your name well. Aguma Bezo. I'll ask you to introduce yourself to the audience, and then you'll tell us briefly what examples you have seen where collaboration across sectors has made a real difference. Over to you, Mr. Aguma.
Thank you very much. Apologies for coming in a bit late. I'm standing in for my commissioner, Mr. Walugembe Frederick. My name is Basil Aguma, Assistant Commissioner Strategic Coordination in the Office of the Prime Minister. And I'm sure in the last few days, we've been talking a lot about integration, coordination, dealing with silos and ensuring that there are synergies and all this. And it's at the center of our mandate as Office of the Prime Minister, which is Article 108, that talks about coordinating the implementation of government policies and programs and ensuring that the different ministries, departments, and agencies and development partners are working in ensuring that government programs are achieved. Now, I want to respond to the question of the examples where collaboration across sectors have made a difference in this country. And let me start from PDM, Parish Development Model. Ladies and gentlemen, you'll recognize that this intervention or this program has brought quite a number of sectors together. You find Ministry of Local Government, the local governments themselves, Ministry of Agriculture, Finance, the cooperatives, the ICT, and gender and the like. And you see with this collaboration, we are looking at aspects of inclusiveness, we are looking at community participation, we are looking at, a coordinated approach really in ensuring that their funds are there, the inputs are there, people are trained, and households at the parish levels are able to, handle the enterprises that they have received money from. And that should help us to appreciate that collaboration, integration is very, very critical. We also saw recently in the last few years when we had COVID, how different sectors came together. And this is where we should also borrow a leaf Ministry of Health was very instrumental in this. And you saw security, ICT, education, trade, and the local government joining hands, leave alone the support that we received from the different NGOs, development partners, those who are investing in the country. And this multi-sectoral approach made a big difference. And Uganda was actually became a story, a model to learn from within the region. And therefore, if we are to succeed, even as we're talking about, the dealing with the non-communicable diseases and these communicable diseases, we need to join hands. Maybe the last one that I can talk about is the disaster risk reduction and management. Many of the times when we are faced with disasters, we've seen Office of the Prime Minister together with other stakeholders coming in, including the UPDF, Ministry of Water Works, agriculture, and the like, coming in to ensure that, there's that collaborative approach in handling the disasters that we face. And in the Elgon region, we've had a number of disasters. Recently in Chitezi, different partners came together, and it was able to leverage the situation. So you find in such a situation, in such a case, there's faster humanitarian response, and we are able to rescue lives and property of the people affected. So maybe those are the few that I can talk about, and aware that, we've had a multi-sectoral approach, especially in the management of HIV/AIDS and the like, and you saw how we made a big difference in terms of fighting the scourge and ensuring that the numbers in terms of the infections are reduced. So thank you very much.
Thank you very much, Mr. Aguma. And thank you again for reiterating what we seem to see as the Ugandan approach. We come together for disasters and emergencies and crises. I think Grace also alluded to that. I just have a short story before I go to my next panelist. About 10 years ago, we were doing work in Eastern Uganda, and we were trying to generate resources for maternal health. And we tried to look around the community to see what kind of resources they generate together. And we learned that they actually collect money for Christmas meat. So they start at the beginning of the year and they collect money which they share at the end of the year to buy sizable amounts of meat. So we asked them, can't you use the same pot for health? And they said, but health is personal. Health is personal. But they do the same thing even for funerals. When someone loses a family member, they will collect money, but not for health, not to sustain health. So we need to change that because I see it trickles across all sectors. Ms. Shirley Kansabe, are there any successful examples of multi-sectoral collaboration between health, agriculture, education that Uganda can build on?
Thank you so much, Prof. My name is Shirley Kansabe. I work at Chambogo University as a research officer. I'm also a PhD student at the School of Public Health in Makerere. I have an interest is eating meat. At least we are sure that that community would eat animal source foods at least once in a year, because we are fighting a lot with the consumption of animal source foods in this country. And back to your question, are there successful examples of multisectoral collaboration in Uganda? Yes. But also we need to reflect and ask ourselves, what counts as success in multisectoral collaboration. Mr. Waguma has talked about some examples, like the PDM. I also want to speak to, just to mention, the program-based approach. It is a policy framework that is forcing us to work in a multisectoral setting, whether we want it or not. And I think that's a plus for us. I may not speak so much about the program-based approach, but at least we know for human capital development, it's now no longer only the Ministry of Health, it's also education, it's also water, and gender, labor, and social development. So I'll speak more about a multisectoral arrangement in this country that I'm more versed with. It's called the Uganda Nutrition Action Plan. Mr. Waguma probably knows about it because the Office of the Prime Minister is the one that coordinates it. We have about 13 ministries, departments, and agencies of government coming together to make decisions about nutrition. And I want to say that this is an example I want to give as being successful based on the outcomes and not just the collaboration dynamics, the outputs of the collaboration, but the outcomes. So consistently, we've seen stunting reducing in this country and continuing to reduce. The Uganda Nutrition Action Plan has contributed significantly, at least based on the evidence that we have. And the biggest reason for that is because it's bringing a number of actors together. Like I said, it's about 13 ministries and departments coordinated by the Office of the Prime Minister. They have a number of coordination meetings every quarter, and these are the people that meet in these meetings are representatives or nutrition focal persons from each of these ministries. They also oriented when it first started. We're going into the third phase, but when it first started in the first UNAP and then the second, there's been orientation. And this is important because when you go to the Ministry of Education and you're telling them about nutrition, it might not become obvious for them that they have a role to play. Yeah, they may not understand that they have a role to play in reducing the stunting rates. So you'd have to do some bit of orientation, and I really applaud the Uganda Nutrition Action Plan for doing that. The arrangement of this plan is also very interesting. It cascades from the national level to the subnational level. At the national level, we have what they call the MDA Nutrition Coordination Committees. So if, for instance, the Ministry of Health is taking part in this Nutrition Action Plan, they have a committee within the Ministry of Health. They have a committee within the Ministry of Education and all other MDAs that are taking part. And this is very important because then we can be assured that there is buy-in at institutional level to contribute towards this multi-sector initiative. But also when we go to the subnational level at the districts, we also have what we call the District Nutrition Coordination Committees. And these are represented, they're chaired, they're by policy, they're supposed to be chaired by the Chief Administrative Officer, and then the members of these committees are the heads of department at district level. We also have nutrition focal persons who are responsible for ensuring that these committees work. So of course, this is not happening in all the districts in the country, but at least we have had some funding for a number of them to start to work, and for others to sustain the work that they have started on. I want to say that it is turning out very interesting because the people in health or agriculture that we think should be well versed with the issues of nutrition and how they eventually affect our health, sometimes are not very keen to engage in these discussions and to move this work forward. But when we go, for instance, to the person working in water, you find that they are very enthusiastic. They understand that they have a contribution to make. They move forward. They ensure that their committees at the ministries are working. And we finished a forum, a nutrition forum the previous year. And some of the sectors that performed better, that were recognized, were those that we didn't expect, especially like I've given an example of water. The enthusiasm was so much, the work was so much. They were so much interested. They've done so much more across the whole country. They've incorporated nutrition in their water committees. They've incorporated their nutrition in the outreach activities, which is very important. And lastly, I want to speak about the commitment or the motivation to work multisectorally. This is something I think that we struggle with everywhere. Where is the motivation and where is it coming from? Because everybody wants what they want in a collaboration. They come with their specific interests. Yeah, so their interests at some point might have to, to be overridden. They might want their interests to be above the interests of others. And so that kills the spirit of working together. So what we've seen in the Nutrition Action Plan about commitment is that people who have resources, maybe from donors, they seem to be more committed to this work, but also how they perceive the problem of malnutrition in this country has been something that has contributed to their motivation. There is also a need to build trust when we work collaboratively. Building trust should be something that we work on actively to ensure that we are not thinking that someone is hiding something behind us in the guise of working together. They're running their own agenda or something like that. So of course that comes with transparency. Thank you so much for that.
Thank you very much, Ms. Kansabe. The recognition that oftentimes we've left health to handle all the malpractices or the mispractices which emerge from other sectors is indeed something we need to address, whether the challenges come from the water sector, the food and nutrition, transport. Everything is ultimately handled at the health facility, which I think is overwhelming. So I'm glad you've shared a model for improving nutrition at all levels, and perhaps even making environments more conducive for nutrition, even in the schools. Hopefully that is something the private sector can take on. We have 30 minutes to the end of this session, and I am informed that our keynote speaker, Professor Francis Omaswa, has arrived. I am going to officially, you don't invite big people when you're sitting. Allow me to stand and invite. So ladies and gentlemen, this is how we are going to proceed with the rest of this session. I am going to invite our esteemed keynote speaker, Professor Francis Omaswa, the Executive Director for the African Center for Global Health and Social Transformation, and the Chancellor of Soroti University, to speak. But before he comes, I want to briefly speak about him. Professor Omaswa was previously the Director General of Health Services in the Ministry of Health in Uganda. He coordinated major reforms in the health sector, including decentralization, quality assurance, as well as sector-wide approaches. He has a keen interest in access to quality health services by rural populations, and he spent 5 years testing various approaches for this at the Ngora Mission Hospital in Uganda. He has been the Chancellor for Busitema University. He has been the President for the African Platform for Human Resources for Health. He has been a special advisor to the WHO and the Director General and founding Executive Director for Global Health Workforce Alliance. And this is just part of what he has done. Please join me with a hearty hand clap to invite Professor Omaswa to speak to us. Professor Omaswa, please. Yes, now. And then he will join us on the platform. Thereafter, we will conclude the panel. Thank you very much.
Good morning, ladies and gentlemen, and thank you, moderator, for the introduction. Initially, when I got the invitation to come and speak here, the letter said that I would be making the closing address in the afternoon, 3 p.m. or something like that. Then I got a phone call this morning to say that I should have spoken already by now, this morning. But that is all okay. The topic which was proposed to me was around public health leadership and health systems integration, and fostering a unified evidence-based approach to communicable and non-communicable diseases. You know, those two, leadership and then communicable and non-communicable diseases. So thinking about what I would share with you, for the last week, from Monday, I've been in Kigali attending a meeting there, a regional global forum on how Africa can influence the global health architecture. And all the time I was thinking about what I could bring from there to you people here. And that is what I'm going to share with you. Point number one. That meeting started by blaming donors, blaming foreign people. But then the conversation moved to blaming ourselves. You know, why are you blaming others for your problems? Why don't you solve your problems yourself? And it ended up on leadership. And maybe that is the most important message that I would want really to share with you here. It is up to us to achieve our health goals. And we can do so, provided that each one of us individually, privately, in our own hearts, commit ourselves to doing whatever we have been assigned to do the best way possible, to the best competences that we have. If it is not going to be done by us, who is going to do it? It is not going to be done where you are working. Where do you expect it to be done? And if you are waiting for others to do first, you need to start now, yesterday, where you are. Why is Africa lagging so much behind other regions of the world in health indices when there are people like us here? That is the real question that we should be asking ourselves. And moving from this meeting, each one of us should live committed to go back to where we work to make sure that we achieve the goals and objectives of our respective offices. It is possible. We can do it. But to do that, we have to become leaders who are inclusive, We have to become leaders who work together with others, because alone we cannot achieve what we want to do. We want to be able to reach a stage in everything that we try to do where you reach the whole of society approach. The whole community knows that nutrition is important, and this is what to eat, this is what not to eat, this is when to eat, this is not when to eat. It should become something that everyone, everywhere is aware of. We have examples where we have succeeded in this. If you look at our response to HIV/AIDS, at one time we reached very alarming prevalence rates, 18% in the general population, some communities 30%. But then we got together, mobilized the head of state, mobilized ourselves with those drums on the radio, so before every news item, posters on the streets, and talking. And it became a matter which society said, this is a problem, let's deal with it. And in a short time, just with that alone, even before ARVs came, we brought down prevalence of HIV from 18% national to about 6%, where almost it is stayed now. So we can do it. It is possible to do it. Is this something we want to go away from here and do for communicable and non-communicable diseases? That is what we should be planning to do, to go and mobilize and switch on the entire community so that we are able to do this. There is also the whole of government approach, which with the HIV, the entire government was part of it, led by the head of state himself, who was making regular statements on this issue. And then the communication ministry got involved, the finance ministry got involved, the local governments, and the entire government was in it. So with this also, we need to find a way of getting other sectors to move with us through our leadership. The whole of government, the whole of society. And to do this, I've seen in the program, you've had sessions on evidence, data, artificial intelligence. We need data. We need to be able to show to the country, to the people, that this is what is happening, and this is what we should do, and this is what we should not do. The world is moving very fast towards using data and artificial intelligence. And I understand that in our Ministry of Health, we have just recently created an office which is focusing on this, although it was there before. Let's find ways of making sure that we generate data on non-communicable diseases, on communicable diseases, which we share with the people. And the data is there. You know, if you take the case of hypertension, so many strokes in the communities, and people know about their relatives who get paralyzed on one side and so on. And if we were to make it known to all our people that that is probably caused by high blood pressure, you can check your high blood pressure. You can have your high blood pressure controlled. This is how you do it. And then it becomes a whole of society intervention where we can impact on the issue of hypertension and strokes. You can take anything else, you know, diabetes, including communicable diseases. How do they spread from one person to another? You know, COVID was a terrific opportunity, which we used very well indeed. At that time, I was appointed by the president to be the chair of the Community Engagement Subcommittee of the National Task Force. And what we did then was to try and pursue this whole of society approach, establish a village COVID task force in every LC1, chaired by the LC1 chair, with cultural leaders, with religious leaders, with the other committee of the LC1 system. And the message got through. We even were able to send money directly to village health teams to do their work, reach every household, know where the outbreak is. So this is where we need to go with our health system in the country. Whatever we do, we must make it a priority for all our people, for all our citizens. How to reach them should be our big focus on concentration. And then getting messages which is easy for them to understand, and getting mechanisms for monitoring what is happening and reporting back and responding to what is happening. The issue of the youth was discussed a lot at Kigali. In Uganda, they say 70% of all the population is below the age of 30. So that's a target group which we should focus on. All our strategies should make sure that we reach that group of people, and we make sure that they are reached using strategies to which they respond. So, my friends, I was told to speak for not more than 15 minutes. Yes. And I think I have done I've done the 15 minutes, but my core message is that it is up to us. We each where we are should be doing what we are supposed to do well. Be committed to that. We don't need to be supervised by anyone else. But of course, making sure that things are happening and they are coordinated is very important. I don't know if the leaders of the Ministry of Health are here, but the message I would have there, in order to achieve this all of society, all of government approach and so on, supportive supervision of the health system is extremely important. And in my time in the ministry, we had a budget for support supervision, coordinated by the Quality Assurance Program. Every quarter, we sent people to every district for 1 week. And during the week, you can even send messages back to the headquarters, say, I've found this here, needs urgent action. But every report of the district 1 week supervision visit would be discussed in detail. And that is the way to keep the momentum going, to keep everyone on their toes. Let no one go to sleep. So, friends, it is possible. Uganda, we have had a good history. We know what to do. Let's just do it. And those of you, wherever you are, each one where they are, go back and become the leader that you are, and make sure that your area of work actually gets fixed. So that is my message. And I hope you will believe me, but without you being leaders, very little will change. Thank you.
Thank you very much, Professor Omaswa, for reminding us that it's not those people doing these things to us. It is us who need to step up and do better for ourselves. I would like to open up this session for a Q&A, and it will also allow our panelists to say more about what they needed to say. So, does any one of you have a question for our panelists? I'll take 1, 2, 3, 4, 5. I hope I've got my gender balanced. Prof. So 1, 2, 3, 4, and 5. Please, can you send mics? Keep your question precise or your comment precise.
Okay.
Where are the mics?
Chair, I'm here. Thank you so much, Chair. I am Kamara Daniel. I'm a nutritionist. I really want to thank Madame Shali Kansabe. She has really presented a very nice presentation. And my question goes to her. We are now trying to fight the triple burden of under, over, and hidden hunger. And of course, as we intend to fight for nutrition to be integrated into the system, what do you think is the best strategy as we wait for the government to put us into the old structures? Because we understand that most nutritionists are left behind in the struggle. I want to thank you.
Thank you very much. I'm Mboge Issa, Chief Administrative Officer of Madis Local Government. I would like to commend Professor Maswa for his efforts in combating, in ensuring that awareness is raised. In 1994, when we were in the university, Professor Omaswa organized a World No Tobacco Day, which raised the awareness about the effects of tobacco by that time. And many youth, actually, including myself, we didn't know that tobacco was a challenge because of peer influence, but it was a changing agent which came to us. And I agree with you that the community involvement will help us. People should be aware of what is the problem. Actually, I always say we should move in the footsteps of Stephen Covey, who said that you have to think about something to have an action. An action brings a habit brings a character brings a destiny. So where do we want? And I'm very grateful that people should be aware of what the community should be aware of what a BMI means. So at one time we were in Japan, and the issue of height is very, very important. That one of the participants by that time, the town clerk of Livingstone City in Zambia, Maria, pointed out that in Africa we don't live to know our height. It is only known by a stick when somebody has passed on when they are going to prepare a coffin. But it is very, very important for your lifestyle to know that if the height I have, I must have this weight for you to go through with all those issues. But we are very grateful. Thank you very much.
Thank you so much. With all respect to my senior, my fellow Heroes for Health awardee, Lifetime Achiever, that one we forgot to mention, Professor Maswa. Very important person to us. Professor Maswa, we are still in the game, and we started together with you because when I joined APAC, you were there, and I'm still on APAC. Civil society, I'm just thinking, this whole integration thing and the whole thing is also related to a mindset change. And I think as much as we sit there and talk about, multisectoral, cutting across the sector, we must have people working in ministries and governments cross over to the civil society sector. So as much as we are speaking about We are up here talking government, nutrition, and whatever it is you want to talk about. The civil society and the community are on the ground, your foot soldiers doing this work. And they have already integrated the work that they do. Because when we go to the community and we talk to people, the consumers of healthcare, we don't only look at a person and say, this person is living with HIV or affected by TB. We need to look at their mental health. We need to look at their nutritional status. So I'm thinking that as much as we talk about sectors in the government, please try to make to know the civil society. We have been there. We are there on the ground. So please remember to cross your sectors from the ministerial level to the civil society sector. Thank you.
Can we have two more and then we allow the panelists to respond?
Thank you very much. My name is Dr. Siyum Dejine. I'm one of the advisors at the National TB Program. I want to go back to Dr. Ms. Shirley Kansabe's submission regarding multisectoral approach and how nutrition committee that started at the OPM went all the way down to the district level. I think seems to be a very successful multisectoral approach for nutrition. But now we are talking about integration. So moving forward, what is the plan? For example, is it possible to, instead of having a nutrition task force, maybe health and nutrition task force to address all the health issues? Because the same committee is needed for malaria, for HIV, for reproductive health, even wash and sanitation. So that's my ask, if there is something that can be done in terms of integrating the multisectoral approach.
Thank you very much. My name is David Guatude from the School of Public Health, and I would like to direct my question to Professor Omaswa. First, thank you for pointing out that I think each of us has a responsibility in making a change. And you have also correctly pointed out or given examples where we have succeeded, the case of HIV, the case of COVID-19. But where do you think the problem is? Because I think many of us have contributed what we can. I'm from the academia, and we provide a lot of evidence. On Wednesday, the permanent secretary was here, asked us we should provide evidence or data. And we have provided data to the Ministry of Health. We have even provided information on interventions that we have tested or co-designed with the community members that work, and we have shown the effectiveness of some of these interventions. So in my view, many of us are playing our role. But where do you think the problem is? Because we have provided what we can. Yes, we provided what we can, and I don't know what is it that is preventing us in moving forward. Thank you.
Thank you very much. I'll now swing back to the panelists to address the questions that have been raised. I think not all my panelists got questions, but those who did, please. Professor Maswa, you want to go first?
Yeah, a very good points, all of them. And the gentleman who was congratulating me on tobacco, it is an illustration on our individual leadership responsibilities. I came back to Mulago here, Makerere, and started practicing as a cardiothoracic surgeon. Within 6 months, I had seen more than 10 people with cancer of the lungs directly connected with tobacco. One of them was a minister. Another one was a senior officer in vet. Another one was had a very high office in the airline, and so on. Very prominent people said, "What do we do about this?" So we mobilized other people, like in the respiratory department, the late Peter Eriki, and the cancer, Katongo Lembide, and we created what was called the Uganda No Tobacco Association. And using that group, we were able to convince the government to adopt a law on tobacco. And we were one of the very first countries in Africa to have this law. It is there. So it is possible to be that leader that brings about change. And I congratulate you, Lydia, for staying on track. And for those of you who do not know, we were among the very first countries in Africa to popularize antiretroviral drugs. And Lydia was one of the champions of that. And of course, Professor Peter Mugenyi, I don't know where he is, but he did a lot to make sure that he accessed cheap ARVs, and together with us in the ministry, Alex Opio and so on, we multiplied the ARV distribution sites very, very rapidly indeed. So when there was 3 by 5, WHO Director General had called upon all countries to increase ARV. Is it by the year 2005, 3 million people would have been on ARVs 3 by 5. In Africa, only 2 countries achieved the targets which were given to us. That was Botswana and Uganda. So we have a track record of being high performers. Now, that brings me now to the question from our colleague from the Makerere School of Public Health, asking a very relevant question. So we have everything, but what is the problem? Why is it not happening? And that is really what our conversation should be about. So we need to have structures inside our governance program where all of us have opportunity to put in what we are able to put in. How is it working? We would have a program like to say revise the National Health Strategic Plan. And we would have big meetings like this so that a role is identified for all the key stakeholders so that the people with evidence have a place. So right now, you said you still have got HIPAC. HIPAC is one structure because the senior management committee in the ministry annual reviews, are they taking place? Yes. They are. And do you get invited to the annual health sector reviews?
We do.
First of all, are they taking place? They are taking place. And do we invite people from academia to these reviews? They do.
Yes.
And then what happens when you are invited there? Are you able to make your points? First of all, tell me, have you been attending joint reviews of the Ministry of Health? You see, he hasn't been. And you need also, as a leader, to find your way of breaking in. That is the other message which I think I was making at the beginning. All of us should contribute. Make sure that you contribute. If you have something which is important, just make sure that it is heard. And no one else has got that responsibility except you. So I think inclusive methods of work, I know we have those structures in the ministry, let's all use them. And those who are in the ministry, open out. And then in implementation, there is what is called the 3 1s. We should all have one national health plan, which is implemented by the second one implementation mechanism where there is a role for everyone and it is very well identified. And then the third one is an M&E mechanism, which again is shared and the results are reported and shared. So the mechanisms are there, but my answer to you is make sure that what you have is heard and implemented. And no one else has a responsibility to do that except you. Don't, when we said don't stop blaming other people, I don't want to say that that's what you were doing, but you find a way that the data which you have is used. And no one should stop you on this. This is also what I found along the way. You get people who are something to contribute, but they are waiting to be invited. But then you get people who have something to contribute, and sometimes they even overrun you. They force you to do what they want to happen. Or they make you do what they want to happen. So that is what each of us should be. Change agents, people who are there to make sure that what they believe in is actually happening. That is the problem. We don't have enough of those. I think, let me stop there. The civil society sector, when we talk about all of society, that is it. We have very many CSOs in Uganda, and they should have a role in the health sector planning and implementation. In that first one plan with different implementers, each one having a clear role which they play, and then we have the whole of government and the whole of society, a movement, and we will get our health goals achieved. The other one I didn't talk about is financing. One of the challenges which we have is underfunding of health. I am told that right now, per capita, we are spending maybe around $45 per capita. When I was in the Ministry of Health, we had gone as far as 65. Why is this? So that business of Abuja declaration, 15% of the national budget, it doesn't work. Let's find social and economic arguments for investing in health. And the people prioritize health. You've got that report, 20, I think it was 2020. The poor being interviewed, what is the cause of your poverty? The majority said it was poor health. So even now the campaigns are going on, people are asking for health centers. So the public prioritizes health, but it needs to be converted into higher investments in health. I get that there are health economists who at one time were saying that health is consumptive. That is wrong. One of the champions of that, I met him recently, it's a while now, 2019, we were in a meeting in Germany, and he was, at the time I was in the Ministry of Health, the chief economist at the World Bank. And he wrote a long article in the New Vision newspaper here in Uganda saying that the health sector here was a bottomless pit. And when I last met him in Germany, he was telling the meeting there that for the last 40 years, they have been teaching wrong economics about profit, profit, profit. What about the people from whom you make the profit from? Where are they in your big picture? So, and there's also been a big study commissioned by Ban Ki-moon when he was Secretary General, the UN Secretary General, on health, employment, and economic growth, where it was clearly shown that health is a big contributor to economies. The economy of health of Germany, for example, 30% of it is around health, manufacturing, trading in drugs, and employment, and so on. So health as an economic issue is at the center of everything. If you don't have healthy people, you don't have a productive nation. Without health, wealth is nothing. So let's find a way of prioritizing health among our political leaders and also among our people. Thank you.
Thank you very much, Ms. Kansabe. If you can be as precise as you can.
Okay. Thank you so much, Prof. I think Professor Maswa has talked about the civil society issue. I think I've also been arguing that when we use the language of multisectoral, we leave out other players. So I see some writings actually talking about the whole of government, whole of society, like Professor has been saying, but also others talk of multi-stakeholder engagement. So in the example that I gave for nutrition, we have other non-state actors as part of the multisectoral team, though they call it the multisectoral, but we also have the Scaling Up Nutrition Academia and Research Institutions Network. It's coordinated at Chambogo University. We also have the Civil Society Network. We also have the Development Partners Network chaired by UNICEF and the Business Network. So these work alongside the sectors, the ministries and departments of government. There was a question about the possibility to ride on existing committees like the one for nutrition to address other diseases. What I can say about that is that economically it would be very good. But what I also know is that everything is possible if we have the will to do it and the resources, and we also, if we can do good negotiations around that. The third phase of the Nutrition Action Plan is under negotiation right now. So that maybe would be an opportunity for us to integrate other services into these existing committees. Then there was a question about a strategy to incorporate nutritionists into the system. As a nutritionist myself, I have seen a lot of the advocacy for nutrition experts to be incorporated into the system to be happening to the Ministry of Health only. But as we speak about multi-stakeholder solutions, I think this advocacy can also go to other sectors like agriculture, education, water. Maybe there would be space there. And since we are all contributing to the same outcome, whether we are working in health or elsewhere, the results, the outcomes would still be seen. And also to note that when we do this evidence, rather the advocacy, it should be evidence-based because that's what moves most of the policymakers. Thank you for that.
Thank you very much. I will also ask my other panelists to give one or two sentence parting shot before I summarize the panel. Mr. Aguma, please.
Thank you, Professor, and thank you, the participants. I want to borrow a leaf from Professor Maswa and also my colleagues. And we need to go beyond the multi-sectoral approach of doing business. We've been implementing the program-based approach for quite some time now. And that should help us to ensure that the different stakeholders who are critical in the implementation of the programs that we do are brought on board. And as I said before, Office of the Prime Minister is critical in this. We are enablers, and you are at the center of this because you know the specifics of what needs to be done. But we can create a platform that would enable us to work together. We already have a strong legal framework that guides operation, and we should leverage on this. The Prof made mention, Professor Meswa, about leadership. And it's very important that we first of all need to know that everything rises and falls with leadership. So at different levels, from the cabinet, to the parliament, the different ministries, agencies, and organizations that we work with, let's provide the necessary leadership that will drive change. And finally, ladies and gentlemen, I want to talk about the need for an integrated approach in terms of planning, in terms of budgeting, in terms of monitoring the activities that we do. You see, we talk of integration, but we still persistently continue with our silos approach in terms of planning, and we are looking at the little resources that are coming in our different organizations. And but if we planned together, budgeted together, monitored what we are doing together, in line with the development frameworks that we are working with, I think we should go a long way and ensure that there is success in whatever we do. Let's not forget about the local governments, because they are at the front line of implementation, and usually they are crying of resources here and there, and it's therefore important that in whatever we are doing, we know that these local governments are very, very critical in the work that we do. Thank you very much.
Thank you. Mrs. Grace Chonuka.
Thank you, moderator, and thank you, Professor, for a really holistic approach to this conversation and reminding us of some of the basics. I think from the private sector perspective, we all know, in light of the journey we've traveled, private sector exists to complement the role of government. Government can't do it alone. Of course, private sector can't do it alone. And interestingly, we're working on a project called FLOWS, Food Loss and Wastage. And we found that 40% of the food brought into urban centers is wasted. It's lost, it's rotten, it's just being wasted. It comes in perfectly consumable, but 40% is being lost. And that is such an opportunity for us to know that what is healthy, as Doctor had said earlier, is actually being wasted when it comes to the city. So we need a new mindset. Everybody has a role to play. The private sector needs to understand its role better, and the government needs to understand private sector better in order to involve it more holistically in the approaches that we're coming up with. And of course, as Professor mentioned, the resources are limited. Much as we're moving in the wrong direction from 65 to 40, we need to also look at efficiencies and how to catalyze other sources of resources to come in, especially from the private sector. Because healthcare is expensive. Just because we have low incomes in the country doesn't mean that healthcare is going to be cost less. It actually is expensive, and I'm sure Dr. here knows full well, much as we want to provide a good service, at times just even the equipment and what the inputs that go into providing a quality service are expensive. So we need to think of ways to mobilize more resources internally as a country so that we are our own rescue. And so I think there's an opportunity for private sector to come in for more screening. and for more preventative steps. And I think if we're engaged holistically, we're able to do that. Thank you.
Thank you. Dr. Sinawulia?
Yeah, thank you so much. I'm really enjoying this. Private sector actually is a great player in this. I think it's close to more than 50% of services are provided by them. And that's a great contribution. So having them on the table really helps us a lot. So as we wind up, like as the Institute, what are the practical ways we are looking at to make this work? We mapped out our partners or our stakeholders. So we invite them or go to them. Recently, in our plannings, the National Planning Authority has really been a key player to help us because they have a bird's view concerning other parastatals. So in our budgeting, much as we might want so much, they'll tell us this one, and they advise us to strategically plan and be able to advocate for more later on. So that collective engagement with something that unifies us as sectors goes a long way. Awareness, like I said, we go to them. We've done a lot of campaigns with the OPM's office. We go to these agencies, URA, we go to judiciary, and our role there is to build awareness, because when we build awareness, they're going to be advocates for us, and we collectively advocate to be able to reach a greater population. But also the patients also, I can't overemphasize this, they are our biggest advocating partners. And I'm so happy to hear the patient or the civil society coming in big. Like I said, I'm a patron for one of the cardiac conditions. And the reason was simply to increase our voice or amplify our voice. One of the patients, who I call my daughter, she sits on the WHO guideline committee. Right now, she's being supported to do masters. And with the aim to amplify her voice, because these lived experiences, they go a long way. Where I can't sit, the time I was in New York and I was seated on a panel, and clearly I realized I was misplaced because they were talking about patients. And that made me go into that journey. How do we empower our patients to be the voice that will help us advocate? And she has a community program. Like, she amazes me at how she has taken it on, and she's actually making our work really easier. In terms of the training, we all trainers, let us be intentional, because many of us, as we work with the patients, we fail to maximize our opportunity to educate them. So that when they go back home, they can actually educate others who can help in lobbying and making these solutions available. So there's so much that we can do, but collectively, let's do what we need to do. Of course, we blame government, but we are the government, and we need to do our roles. Me, I'm not limited. If I dream it, I'm going to do it, because I know once you have the will to do something, you're going to actually do it, and the resources to do it will be available because your eyes are opened to those solutions. Thank you.
Thank you very much, my esteemed panelists. I would like to make just a quick 2-minute run through what we have learned in this panel. Mrs. Grace Sally reminded us that the private sector does complement government across multiple sectors, be it education, transport, agriculture, security, health, and the need to harness that intentionally with pre-planned approaches to avoid the emergency approach, which makes it less observable. Dr. Sinawulia reminded us that awareness about self-care, awareness and health literacy is critical if we are to move from where we are to where we want to go, starting from childhood, using data not only to make decisions, but to educate. Mr. Aguma reminded us of the different models which have worked, the parish development model, what we did during COVID, disaster risk reduction and management, HIV. There are places where we have worked together across sectors to make it work, and there are lessons to learn. Ms. Shirley asked us a critical question, which emerged even last week during the discussion of Uganda's compact. When it comes to multisectoral approach, what is success? How will we know that we have actually achieved multisectoral collaboration. And this is something that begs more interrogation. But she has also taken us through a number of collaboratives which have worked. She has also highlighted the need to take note of interests and trust as we work across sectors. Professor Omaswa reminded us that it's up to us. It starts with us. It will be done with us by becoming leaders, by looking at the whole of society and whole of government. We need data to guide decisions, but also to measure progress, and it's up to us to do what we do and to do it well, to find pathways to making sure that the evidence we generate is used for decision making. I'm excited as Ugandans. We now walk more, we run more, although we try to plan it around marathons. I hope we can do better. But finally, as I close, I want to remind all of us that wealth without health is nothing. I took that from Professor Omaswa. As we look towards multisectoral collaboration, let us remember that where we start from is where we will end. It starts with us. Thank you very much, my panelists. A hand clap for the panelists. Another hand clap because you'll be going for break tea. Thank you very much, ladies and gentlemen.
Thank you, Dr. Suzanne. Members, please appreciate our session chair. She has herself a medal. She's among, you can stand for a group photo. She's among, if not the only chair we have had who has held her session right on time as we had given her. So please appreciate her. As they take the group photo, I would like to also request the IT team to load the guidance that we are going to get for the breakout sessions that we shall have after our break tea, and I will be guiding you through that as I load it. So we are going to have breakout sessions after tea, and the breakout sessions are going to be in the 4 halls like we had yesterday. So we request all the rapporteurs to please take charge of the breakout rooms, but also the session chairs to please report so that we can be able to start on time. In Victoria Hall, those of you who are joining us for the first time, it's where we are now, and we are going to be looking at issues of malaria. And then the other 3 halls are downstairs. In Mera, we shall be discussing issues of HIV. And then Shina, we shall look at child health. And in the Royal Hall, we shall also be looking at communicable and non-communicable diseases prevention and control. So our break tea will be served outside. As you exit, it will be for the district leaders, the DHOs, the chief administrative officer and the district chairpersons. Our tea is right here at the entrance. Then for the heads of institutions, together with our senior leadership from the ministry, the keynote speaker and the panelists, you'll be guided where you'll have your tea like you did yesterday. The rest of us, our tea, we have 40 points down. And in case you actually decide to choose a breakout session, you can go direct and have your tea from there. That's where it is served and put. So we also have an evaluation form to get your feedback on the conference. The ushers will be giving out this form, and it will also be displayed on the screens. You can scan the code and you give us feedback. We need your feedback because it will help us organize and improve the way we arrange these discussions to serve you better. So as we go for tea also, let us appreciate our sign language interpreter, Claire with us, and Mohammed, who has been with us here. So for those of you who may not know, Claire is a staff of the Ministry of Health, just like all of us. So these services are not outsourced, but we have them integrated in the ministry. So enjoy your break tea. Let's keep time. The breakout sessions will be beginning at exactly 11:15 so that we have enough time to discuss. So enjoy your tea. See you after break.
Understand.